I wanted to start with a big thank you. In recent years, actually not so long ago, there was only virtually one GP you could see in the Department of Health and the higher echelons of health policy and government, David Colantomi. That has completely changed. And what you see now in the Department of Health, from a scenario actually where the whole process was dominated by what I like to call partialists, or they were called czars in those days, weren't they? Actually, GPs being absolutely at the forefront of policy making. And the thank you is to a whole raft of people that have brought you a whole raft of things, the rescue plan, the forward view, but a big thank you in particular to someone I describe as fearsome, fearless, and a fantastic advocate for general practice, and who has made so many of these things happen. And I almost don't need to give you her name. Of course, it's your Maureen Baker. In the last few days, I've been at a lot of meetings in Downing Street yesterday, top of the Department of Health. And the other thing I would say to you, and I can't tell you who said these things, but I've heard chief execs of hospitals and people at the top say that when we sell hospitals, we should use the money to build GP surgeries and GP infrastructures. I've heard them all say that plan A, B, and C is primary care. And of course, this all comes out of the 5-year forward view, which in a sense, I think, was a sea change. In my 30 years as GP, it was a sea change, a new approach, actually, to how we were going to deliver healthcare in the future. And there were two very big key things that came out of it. One was the need to shift services from hospital into the community and into primary care. In other words, a big idea about developing, expanding primary care, to the point where actually one of my roles is chair of something called the TST, but also clinical lead for the STP, and we estimate that we need to expand the offering of primary care by 33% in the next 5 years to deliver on that ask. And of course, the second big thing it talks about, for the first time in some ways, was the importance of the social determinants of health. And we need to remind everybody and to be a bit humble in the health service and recognize that only probably 30% of what the health service does is about people's health and well-being. The 70%, and you'll hear a bit about that in the new models of care, is equally and sometimes much more important to patients. When I started at medical school, I was taught to work out what the matter was with a patient. Now, the future is about what matters to patients. A very subtle shift of words, but a very big change in direction. So I started my life at the age of 17 as a welder on the west coast of Norway in a shipbuilding yard. I'm Norwegian in origin. And I came back to the UK and I trained as a barrister. And the reason I'm telling you that is a bit about why I'm not a barrister now, but what I learned as a lawyer. The main thing I learned was actually don't ever go and ask a lawyer a question. You'll spend a fortune for them to tell you why you can't do something. And this is the nub, actually, of what the new models of care is all about. Because what I also realized is the vast majority of things never ended up in court. And that the rule that you need to apply to the new models of care, whatever you're doing, dare I say it, is if you're not breaking the rules, you're probably not doing the right thing. And as long as the focus is absolutely on patients, that's exactly what you should be doing. And of course, I ended up, most importantly, as a GP in Tower Hamlets, and I'm a GP for 2 days a week. Yes, on occasion, seeing 60 patients a day. I know how tough it is for all of you out there at the moment. There has not been a tougher time in my career, 30 years of being a GP. But it also is a fantastic time where everybody sees you as the solution to the problem. So I wanted just to take you back a bit in time in history to, this is the Peckham Experiment, started in 1935 and closed in 1950. How sad was that, 2 years after the NHS was founded? And closed because, I quote, its innovative approach did not fit with the health service. And yet the Peckham Experiment was entirely about the social determinants of health. It was the earliest group that recognized the importance of what matters to patients. I have to say also what it did was integrate different sections of society. 10 years ago, I was at BMA House when the bus bomb went off, and I was one of the doctors who had to deal with all the casualties. And I came home that night and into surgery the next day and thought deep and hard about the importance of our role in bringing sections of society together. I reflected on how could somebody so dehumanize their neighbors to the point where actually blowing them up wasn't a problem or an issue. And I realized the importance of what we were doing at Bromley by Bow, where I'm a GP, in bringing different elements of society together, how important we were in general practice. It's virtually the only place, I'd say, where you could see somebody with a veil sitting next to a young white man. And actually, we need to do something about that in primary care, and how more pertinent it is with some of the fears that are going around with Brexit, the role that we have in bringing sections of society together. That wider role as a GP is absolutely crucial to us. The other thing, of course, I would say that the 48 Act didn't do, it didn't get rid of it, didn't do, was bring general practice and consultants, or GPs and consultants, together. And I'm going to talk a bit about how the new models of care does that. By the way, these are your new models of care. This is what came out of the 5-year forward plan. They are, to a great extent, around primary care and those things that we need to deliver in the 5-year forward plan. And they are really, interestingly, about connecting the policymakers with what goes on at the ground. And that is a very new concept in the policy world, and is the reason in the past why we've had so many of the problems we face now. For the first time ever, you are seeing Simon Stevens or whoever absolutely connected with what you're doing at the grassroots. But I just wanted to focus a bit on that 70% that I talked about, the social determinants of health, social prescribing, we call it now. Now a big movement. There's a national network now of 100 organizations as part of it, and every single one of the new models is involved in some sort of social prescribing project. And of course, just recently, Mike Dixon, one of your GP colleagues, has been appointed to be ambassador for social prescribing in NHS England. So what are these things? Well, first of all, the environment, absolutely critical. This is Tower Hamlets, it's Mile End Road, it's known as Chicken Shop Mile. These are 5 chicken shops in a row. There are 42 chicken shops per secondary school in Tower Hamlets. And I jest not when I say I recommend to my patients McDonald's, that's the healthy end of the market. This is the environment we live in. And a typical 5-year-old in Tower Hamlets will be 50% vitamin D deficient, 50% dental caries, 10% below the national average in terms of cognitive development, obesity 11% at the age of 5, doubled by the age of 13. There is a big task for us, isn't there? And guess what? It's not about drugs or hospital treatments. It's absolutely about the social determinants of health. So we talked a bit about the environment, education and employment. This is one of our ESOL, English Second Language classes at the Bromley by Bow Centre. Education and employment is critical to people's health. If you can get somebody into a job, if you can give them any type of education, you will make them better. And actually, very often with my patients, actually, it's the biggest thing I can do. I remember a patient in Tower Hamlets coming to me, and I thought in the early days, and I thought I was being very wise by suggesting that I should refer him to a social worker. And he said to me, Sam, I don't need an effing social worker, I need a social worker's wage. And doesn't that make a very strong point? And of course, finally, people's creativity and spirituality. And this is at our health centre. This group is called the Young at Art. They're a group of elderly patients who are doing amazing things around art and obviously doing things about their health and well-being. I recently did a keynote speech to the National Gardening Scheme, which was really interesting. And these are people who open up their gardens and make millions for various charities, including Macmillan. Absolutely amazing people. But I looked at the audience, and they were all 70, 80, and 90. Virtually none of them was obese, and they were all happy and healthy, and there lies a tale. And out of that came a project, and we delivered a policy document at the King's Fund on health and gardening. And guess what? Launched by Mary Berry. I remember having breakfast with her not so long ago and going on Women's Hour to talk about gardening and health. And of course, this is now happening around the country. So this is Mike Dixon's in Devon, and this is the Colne Valley, integrated care for health. So not a surgery, but integrated care, a cafe right at the front, a healthy cafe, and a herb garden as part of it. Then there's the Lambeth Co-op, food co-op, that's building gardens in GP surgeries and doing amazing things around food. And then we come to some of the vanguards, because actually there are vanguards across the country. There just happen to be some that are named by NHS England. But we're all part of the same project. And this is Tower Hamlets, which I want to tell you about. And I'm going to point somebody out in the audience. I have warned her in a not too distant future, and tell you a bit about what we're doing in Tower Hamlets as part of the Vanguard project. Well, the first thing is bringing care out of the hospital. And Sally Hull, who's sitting just down there, do go and talk to her afterwards about what she's doing. We now have a scenario where we can get a turnaround from a renal physician in 48 hours, okay? 48 hours. And those renal physicians can look into our notes, into the hospital notes, and give us advice within 48 hours. Now, how good is that? Absolutely amazing. And what I'd say to you is one of the joys, something I didn't expect, actually. Remember all those outpatient letters you get all the time that waffle on around a whole raft of things, and you try and work out what is the grit in it, the important thing? Well, actually, when you get something back for the renal physicians, guess what? They're answering your question in real time. The drugs the patients are on, in real time, they're answering your question and telling you what to do. Now, isn't that fantastic? When I saw a certain person the other day, he thought it was absolutely amazing. He wanted to do it in 3 disease areas. I told them they weren't being ambitious enough. Actually, we need to do it for the whole outpatients. I call this the end of choose and book. And the beginning of choose and consult. Booking, how old-fashioned is that? That's like going back and going into your bank to get money. It's bizarre and perverse. And of course, we started this project last week at Barts, and the plan is to do the whole of outpatients on the lines of the renal project. And we're doing it with the Staff College, the Army Staff College, which is very interesting, because this is all about leadership and change. The idea is to capitate the budget in outpatient and absolutely incentivize the specialists to manage the whole of the patient pathway. It's like going back to the past 30 years ago, where you wrote to a named consultant, and guess what? They rang you, or they met you at a postgraduate meeting, and you dealt with the problem straight away. They triaged. Notice the different scenario now. You've come to the end of your knowledge or whatever, you're asking for help, and guess what? You've got 6 weeks to wait till somebody sees an outpatient. Nobody triages. They do the tests again. How perverse and bizarre is that? It's what I said about bringing back. What the NHS Act failed to do was recreating this relationship between consultant and GP. And why shouldn't all of them be e-referrals with your mobile phone number? They can ring you. They can ring the patient. Book them in for surgery if they've had 6 episodes of cholecystitis. You know, anything, by the way, that saves, one of the key themes in the new models of care, anything that saves patient time will save you time, will deliver far better care. And it's such a solid principle throughout. And while we're at it, we're going to end consultant-to-consultant referral bans. And why should we do this? And why should we do this? Because nobody, no clinician should ever be a partialist again. They all need to be generalists, managing the whole of the patient, not one small part of their body. And an example of this is a diabetes project in Tower Hamlets as a new model. So let me tell you the outcome straight away. Best cholesterol and blood pressure control in the country, despite the deprivation of the area, with early evidence of reduction in heart disease, stroke. I would say to you that when we talk about the fantastic stroke units, do you remember politicians always used to talk about them? And you're talking probably about less than 100 lives saved. I would put to you that if you start doing this, intervening earlier on in somebody's disease process, you will save thousands, tens of thousands of lives. Dare I say it, at a much lesser cost to the health service. How do we do this? A contract with confederations. So the GPs are all confederated in 8 confederations, and now one whole confederation for the whole of Tower Hamlets, by the way, who are in the process. It's going through due diligence, but have been awarded potentially the CHS contract, have the health visitor contract, and guess what? Are actually circling around all the general practice to give them support, so that we have single-handed practices in Tower Hamlets that will be survive and sustained. But actually what we have is an arm around everyone, supporting them in their daily work. The second thing is we create dashboards, clinical dashboards, so you can see, and to my embarrassment at one of my surgeries, the one I work at, we were the worst antibiotic prescribers in Tower Hamlets. Now, I'm ashamed of that, but guess what? We did something about it straight away, because we can create, and Sally and her colleagues in what we call the clinical effectiveness group give us real-time data, which gets us actually to really focus on quality improvement. Regulation is not, absolutely not going to give us the improvement in quality. It's these sorts of projects that will. We give learning time, protected learning time once a month. But most importantly, I wanted to tell you about Taz Chowdhury, our diabetologist. And I call the process, sometimes I call it infecting consultants with general practice, and sometimes I call it Tazzing after him. Taz was given the task on day one, by the way, we don't want to talk about outpatients, but your job is going to manage every diabetic patient in Tower Hamlets. Oh my God, how the hell am I going to do that? Guess what? He realized that he gives his mobile number to the GPs. He goes round, he talks to them about what's the latest, the complex patients. And guess what? He's considered an absolute hero by the GPs, and he is the most amazing consultant. Now, how much better could that be for him? So not only do I want to change the role of the consultant, and by the way, we have a forward view for general practice. Isn't it time we had a forward view for consultants and a forward view for nurses? And isn't that an important part of what we develop? This is about workforce, okay, and the new workforce. And this is one of the nursing teams in one of the surgeries in Tower Hamlets, and I can tell you there that there is a practice nurse who's a full profit-sharing partner of the practice. There is somebody who's a phlebotomist who knows all the patients and will ring through to the GPs and say, I'm worried about this patient, and my God, she's right, with no formal schooling. There is somebody who's an HCA who's going on a training program, and there's one of them there who's a nurse practitioner who manages all the housebound, the terminally ill, and the complex care. I do Mondays and Fridays, and I'm on call on those days. In a practice of 11,000 patients, it is unusual for me to have a home visit, and that's because of this nurse. And this is one of our GPs, because actually it's all about doing things in a very different way. And this is eczemasaurus exercise with, and what these families are doing, they're all kids with eczema, and they're all doing drawings of dinosaurs, or eczemosauruses, as she called them, but more importantly, learning about actually how to manage their chronic disease. So let's go much wider, because this is a project across the country. And I need to apologize that I can't include every general practice in this, because my point right from the beginning was that you are all vanguards. There are some that have been specifically chosen to drive the policy agenda, but actually you will have similar stories to what I'm telling you across the country. So this is a group. Now, I think there's hardly one of you here that wouldn't want to die at home surrounded by your loved ones. And yet in this country, between 50 and 60% of people with terminal illness die in hospital. How can that be right? So this project of experienced nurses on call 24 hours a day have reduced that rate from 48% in their area to 14%. And how have they done that? Something very simple. The patient with terminal illness can Skype consult them at any time. Now, why that is so important, of course, is I would tell you a bit about what one of the patients said, which I think says it so powerfully. They said, look, I am now in charge of my life and death. I can call for help when I need it, not when a doctor decides they've got a clinic or a GP decides they've got time to do a home visit. I'm in charge. And guess what? This actually reduces the workload. I give my mobile phone to all my terminally ill patients. You know, actually, I worry about them not ringing. It reduces my workload. It's counterintuitive to some people, but it absolutely does. And they've done the same sort of project with nursing homes. And in front of them is Kate Granger's husband. This was at an Excel conference this year, who was, to many of you, you will know her as a hospital doctor, who had a just amazing but very simple project, which was just about care and compassion, which I would suggest to you is what general practice is. Hello, my name is Kate Granger. And this project was one of the shortlisted awards for the Kate Granger Award. Time Out is another project. And basically, it's a cafe open every day of the year where people with mental health problems can come in and talk to specialist experts or whatever. They've reduced acute admissions, psychiatric acute admissions by a third. This is Principia. Yes, they're doing street doctors, so they're doing a lot on social prescribing, but they've also got consultant gynecologists, a bit like the renal physicians that I've described, doing that sort of project, and a substantial reduction because of how they're working in a new way as MDTs with the ambulance call-out to care homes. We have Stockport, another vanguard, who've got a hotline to consultants. Means you can ring up at the hospital, like we can at Barts actually. We can ring up on a GP-dedicated line and get through to any consultant on the phone. And why not? I was on the west coast of Scotland out at sea recently, and I was ringing a consultant at the hospital and got straight through to them. Isn't that actually how things should work? But most importantly, because of that, that's reduced through that conversation 70% of those referrals to hospital in those acute situations. There is the MRAD project. This is what I define as anytime, anywhere. It's a very simple idea. It's within a health economy, anybody, anytime, anywhere, any clinician can see somebody's X-ray. And shouldn't that be the norm? We now in Tower Hamlets can see a substantial part of it. The blood tests, the CT scans. So when the patient comes in and says, tell me the result of the CT scan, and you say, who requested it? Didn't they give you a follow-up appointment? Yeah, we all recognize those things. Actually, it's no problem. It's right there on the screen for us. And shouldn't that be the normal throughout the country? Then there's Mid-Knots, who with their multidisciplinary teams have managed to avoid 1,500 admissions since April 2015. This, if you live in Wigness, is somebody you'd know is your superhero. Now, in my neck of the woods, it's Arsenal and football players, but in Wigness, it's rugby players. And what they did, what the rugby team did there was the coach, who's also very famous, has gone into 30 schools and has taught kids about health and well-being. And this particular rugby player went into a residential home with people with a lot of memory problems. And there was just such a lovely moment where he invited them all to the rugby match, and they were all sitting in a line, and he walked across and hugged one of the guys, and for the first time ever, the guy recognized what was going on, recognized him, because of course, Wigness had been something that, the Wigness rugby team had been his youth. Very different ways of doing things, isn't it? And very exciting. And then, so I'm obviously a sailor. I've given you a hint about that. And if you're a sailor, if you're a safe sailor, you'll have a grab bag. And that's as if you're about to sink, you've got all the bits and pieces in there that you grab when you jump into your dinghy or whatever. This is one of the vanguards in London, the Sutton care homes. And this is their equivalent of the grab bag. It's called the red bag. And in it is all the information about a patient and the ability to put in the glasses, the dentures, whatever it is. But it's everything that a patient needs. But more importantly, just a simple thing like that delivers reduced admission to hospital from 12 to 8 days. So I think I've given you some illustrations of the 5-year forward plan across the country. It's about shifting things into primary care. It's about the social determinants of health. It's about social prescribing, which, by the way, as a CCG, we have put the money aside, 240,000, it's £1 per patient, to put the model in every practice in Tower Hamlets. So at the desktop of a GP, you have a referral form, which you can tick the box, lonely, depressed, or just help. And that goes to the social prescribing team. They'll spend an hour with the patient and they'll connect them potentially to 1,500 voluntary sector organisations in Tower Hamlets. A click away, you now have a whole opportunity which is equal, dare I say it, to drugs and referral to hospital right at your fingertips. The doctors love it because it's so simple and easy. And guess what? It's wonderful for those patients who come back to you time and time again. You need to think, just what can I do? The patients love it because it's about what matters to them. The voluntary sector love it because they don't need to market their wares anymore. It's done automatically. Think of all those leaflets you get that you've forgotten 10 minutes later. You don't need to worry about that anymore. And as a hard-nosed CCG chair, do you know what? I love it. Because anything that can divert a patient from NHS services is a good thing as far as I'm concerned. We face, I think, one of the biggest challenges in the NHS in my 30 years as a GP, a fantastic financial challenge. But the bigger challenge, I think, is summed up by what our CEG colleagues produced in research terms. 11 years difference between rich and poor of life expectancy in Tower Hamlets. But in some ways much more shocking is 20 years difference in quality of life. What do I mean by that? I mean, at the age of 55 in Tower Hamlets, you are 75 years old. You know, it's not going to be the genomes, it's not going to be the drugs, it's not going to be specialist care in hospitals that actually gets rid of that big divide. It is absolutely about the social determinants of health. It's absolutely about shifting care in the community. It is absolutely about you. You are the future. You are Plan A, you are Plan B, and you are Plan C. And you are that because of what you are. And we often say this at Bromley by Bow, we define ourselves as a practice and as a charity, not in terms of outcomes or population cover or anything like that, but in 4 simple terms, which I think define general practice and primary care so closely. It's about compassion, it's about friendship, it's about assuming it's possible, and actually, it's about having great fun. And I hope in the pictures that I've showed you, you get the sense, actually, of the fun that people are having in delivering something very special to patients. So thank you, as a GP, on behalf, actually, of all the people I spend time with at the STPs and CCGs, for all the work you do and for the fact that you are now the future.